So thank you for turning up on this Sunday morning, I see. So we'll be talking about human amniotic membrane preparation and applications. So as you all know, amniotic membrane is one of the most versatile tools for the ocular surface surgeon, not only for the ocular surface, now it is finding its use for the glaucoma surgeon, for the squint surgeon, oculoplasty, and even the retina people are dabbling with it. So for this talk, we'll limit ourselves to cornea and ocular surface primarily. And I'm Soham Basak. I'll be talking a little bit about the amniotic membrane preparation, how you can do it yourself if you have a very basic microbiology setup. I'll be joined by my co-instructors, Dr. Tuhin Chaudhuri, Dr. Aditya Pradhan, and Dr. Nidhi Gatkar. So they'll be talking about how to go about using amniotic membrane in various surgical scenarios, from acute to surface reconstructions to adjuncts for different surgeries. So I've kept the topic as such, but mostly these are clinical scenarios with considerable overlap. So there is no way of sort of limiting yourself between these talks. But they'll be taking you over most of the surgical part. I'll be dealing mostly about the preparation part. So if you want to know a little bit history about it, so it goes back more than 100 years back when it was first used by Davis for dermatological purposes. And the first ophthalmic use is recorded for D. Roth in 1940. So that's also almost 80 years plus. And then this is Sorsby and Simmons. They have described it in how to use it in chemical injury. And this is Dr. Schaefer-Seng, who really popularized using amniotic membranes in the late 90s and then the noughties. So he has used it. He has multiple publications of how amniotic membrane can be used for pretty much every clinical scenario under the sun. And if you look at, this is just a timeline graph from the PubMed. So if you look at how the publications have increased, so again, it's like the late 90s when the amniotic membrane really became popular and people sort of started using it. So how does it all work? So without the labels, if you look at the basic histological diagram of amniotic membrane, it looks very similar like that of a corneal structure. So you have an epithelium, basement membrane, a stromal structure, then again a basement membrane internally. So this is the histology of it. So extremely similar to both cornea and conjunctival histology. So the other features would be that it is translucent. So even with an amniotic membrane on, you can sort of see what is going on underneath it. So it allows you to have some clinical evaluation. So it is avascular, and it is taken from the innermost layer of the placenta. The basement membrane again has structures similar to the corneal basement membrane. So collagen 4-7, fibronectin, laminin, and hyaluronate. Then stroma has again three parts: the compact layer, middle fibroblast, and the outermost acellular layer. Then that goes to the anatomy. Now the other advantages is there is no immunogenicity. So this is something which is connecting the mother and the child. So definitely this is something which has got no immunogenicity. And it has got extremely tough tissue. Although it's like so thin, it's very difficult if you want to try and stretch and tear an amniotic membrane, you will find it's very difficult. Because this is something which is bearing the weight of the fetus plus the fluid. And it has got good moisture retention capacity, also due to the presence of hyaluronate. And it has got this huge mix of all these chemokines and growth factors. Coming to this next. And another thing is this chemokines and growth factors, these are also preserved when stored at -80. So how does it all work? So one, it promotes epithelialization. So all aspects of it. It promotes cell growth, cell differentiation, and cell adhesions. It has got antifibrotic properties by suppressing the TGF-beta and myofibroblast differentiation. So as we all know, all these chemical injuries, Stevens-Johnson's, these are all basically induces a tremendous amount of fibrosis on the ocular surface. So acute stage amniotic membrane will help in arresting that fibrotic process. Anti-inflammatory properties, including IL-10, interferons, fibrin growth factor, TNF, and MMP9. So this is all prevented by it. It has got anti-angiogenic properties also. So it prevents corneal vascularization. Then there is antimicrobial properties with a little bit of mechanical barrier, and also this lysozyme and beta lysine in there. So types of surgeries, just briefly, my other speakers will be talking in detail. So we have an inlay technique. So you have a defect and you fill it up with amniotic membrane. That's the inlay technique. Then you have an onlay or an overlay technique. So you have the entire surface is unhealthy, you can cover it up. So whether it can be the cellular side down or cellular side up, this is a little bit of a debate, but each surgeon can have their own preferences. And there can be a mix of the two. So you have a lot of defect with an unhealthy surface, so you fill it up with a multi-layer amniotic membrane, and then finally cover it up with a larger sheet of amniotic membrane. Coming to the types, so what we are commonly used to using is a freshly harvested, which is then processed and then stored. Then what else we can have is the cryopreserved or the lyophilized. So the advantages, this can have a very long shelf life, you don't need to do the processing. Disadvantages, these are slightly less effective if you look at the literature, because since they undergo a lot of this processing, a lot of the chemical properties of amniotic membrane is lost. So it's more of like just a scaffold part which is the active. And then this is something which is known as a Oro Amsarta. This is developed by Dr. Bhaskar Rai Chaudhary. So this is basically a set of 2 silicone rings which can help as we can trap the amniotic membrane sheet in between those 2 silicone rings. So you have like a sort of a conformer. So you can make your own Procera basically. So the delivery system says freshly prepared. We are attaching it to nitrocellulose paper for ease of use. Amsarter, Procera, we can just use it like a contact lens. So it helps in keeping it attached to the surface. Also, you can maintain the fornices along with it. And people have been experimenting with amniotic membrane extract drops, but there has been some regulatory warning from the FDA. So coming to preparation of amniotic membrane. So sourcing of the placenta. So you want an uncomplicated C-section for your placental source. Talk to your obstetrician friend who will be able to provide you with that. And all we need is basically a serological profiling. Usually all of these women undergo serology profile antenatally. In addition, you can always reconfirm it with the cord blood. Hep B, Hep C, HIV, syphilis. These are the commonly done tests. During the peak of COVID, we were doing the RT-PCR with the cord blood, but now slowly it is losing the relevance now. And always it is best to prepare it on the same day. So you should have your lab personnel ready and all the materials ready accordingly. So in terms of the equipment needed, you need to have a set of these graduated flasks, beaker, and cylinder. This is the main investment that is required, a filter pump with a sterilized tubing which can be re-sterilized by autoclaving. Filter paper, pH meter, a digital weighing scale, sterile bottles and caps with heat sealing and labeling, and a laminar flow hood. So if you have a microbiology setup or an iBank setup, most of these are already available with you. So probably the filter pump and pH meter are the only things that you would have to invest in. And these are the chemical components which are required. So this is the main thing. So you can source from any of the standard chemical companies like Sigma Aldrich or High Media. So these are very standard chemical powder providers. So Dulbaka modified Eagles media, that's the main thing. Then sodium bicarb. Antibiotics is streptomycin, penicillin, and amphotericin B. Reverse osmosis filtered water, glycerin, normal saline, nitrocellulose paper, and little quantities of sodium hydroxide and hydrochloric acid. This is for fine tuning of the pH adjustment. So if you look at it, this is very similar to composition to that of the MK media. So you have a nutrient part, then you have something which deterges us, and you have an antibiotic component. So this is the basically 3 things, and a buffer component basically, which is sodium bicarb here. So this is the thing, we bring it in an ice box. I'll just play the video and pause accordingly. So initially we start by extracting the cord blood. So just squeeze the umbilical cord, you will get some cord blood, which is then we do the rapid serological tests. Then this is the mixing of the Dulbaka media. So you mix it, and this is connected to the pH meter. So pH of about 7.2 to 7.4 is acceptable. So if not, then you accordingly, if you have a low pH, add sodium hydroxide. If you have a high pH, add some hydrochloric acid. That's how you adjust the pH. In small quantities, mix, and then take a reading again. So then this entire mixture is passed through the filter. This is the filter pump. So you pass it on top and put the filter papers in this component here, and then the pump system sort of drives it through it. So any impurities are taken care of. So this is your mixture of RO, glycerin, dalbacomedium, sodium bicarb, and the antibiotics. So this is your base fluid which is ready. So once this is going on, this filtration process takes a long time, about 30 to 40 minutes it takes. Once that is ready, you start preparing your amniotic membrane. So the entire placenta is thoroughly washed. So we wash it with normal saline, and in the normal saline we mix up some of the same antibiotics also. So it is basically we are washing it with a very dilute antibiotic solution. You wash it 3-4 times, take out all the blood, and this is how the amniotic membrane. So you just try to lift up the edges. At any one point you will have an anatomical plane from which you can directly take the amniotic membrane up, and the other person can just slowly remove the chorion part of it. And it comes off like this sheet, and it's very tough. So you should not be worried about tearing it, because it's very difficult to tear it also. And then this is the nitrocellulose paper. So once you have a considerable amount which is separated out, apply the nitrocellulose paper and then cut it in strips. So from one placenta, usually you can easily retrieve about 20 to 25 1 inch by 1 inch small squares of amniotic membrane. And the best part is if you're making it on your own, so you can have multiple sizes of it. So we usually cut it into 2.5 into 2.5 centimeters, but then some of them we keep it at a larger size also. So that is as per the surgeon's requirement. And then finally these are transferred to these small glass bottles. They are capped, and then a heat seal is applied on top. So you basically put a small plastic transparent sheet, and with a hair dryer you heat seal it, and then they are labeled for the date and lot number. And then this is stored at -80. So this entire process takes about 2 hours-ish to complete, 2 to 2.5 hours it will take to complete. So coming to the quality control and storage, so whenever you have made one amniotic membrane and the fluid is sent for culture in blood agar and SDA. So only after it has passed all the culture negative, then only we start the distribution process. Ideally to be stored at -80. Then you can store it for a period of 3 months very easily. -20 is also fine, but then the storage time becomes shorter. You should ideally maintain a distribution log, an adverse reaction log, and a freezer temperature log. So then you can have a good quality control. So to conclude, AMT is a very versatile surgical tool for the cornea and surface surgeons. And even comprehensive ophthalmologists should know how to use a very basic AMT for acute ocular emergencies. And novel applications, of course, are coming up. And if you have a very basic microbiological setup, with little more investment, you can learn how to make your own amniotic membrane.